First, I would like to extend my sincere condolence to my sisters and brothers in Morocco and Libya about the devastating life lost because of the earthquake in province Al-Haws and in Derna city because of the devastating floods. These are the outlines of my talk. But first of all, we have to define that according to the European guidelines, the chronic coronary syndromes have 6 common scenarios. 5 of them at least need to be treated with antiplate, either mono or dual therapy, to prevent thrombotic events. And our great friend, the old friend, is Clopidogrel. It was approved to be used since 1997, FDA approved. And since then, it was the only safe drug to be used in combination with aspirin and treating patients with either acute or chronic coronary syndromes. The problem with Clopidogrel, it has a very complex pharmacokinetic, pharmacodynamic, and pharmacogenetic characteristics. And this problem of genetic abnormalities or absorption problems of Clopidogrel had done a great warning from the FDA in 2010 about the usage of Clopidogrel. And the recommendation was that, that many studies shows that patients with variants in cytochrome B450 to C19, shortly known as CIP to C19, have a lower levels of active metabolite of Clopidogrel, and this will lead to less inhibition of platelets, and there is an increased risk of thrombotic or cardiovascular events up to 3.5 times. And this is because of the problem of the metabolism. About only 15% of Clopidogrel will be converted in the liver by the active cytochrome B2C19 into active metabolite, which will work to prevent platelet aggregation. The rest, which is about 85%, will be lost. And this makes the great problem of using Clopidogrel in patients who have some sort of problems regarding the activity of the enzyme cytochrome B, C2BC19. Okay. So Clopidogrel has a very complex metabolism, multiple genes involved in absorption, activation, and inhibition. And the genetic studies reveal that loss of function related to cytochrome B2C19, and especially the mutation at position 2, will lead to what we call as loss of function. And the most common genetic mutation is the position 2, and it's quite common among the Asian population, about 50%, and 30% in the Caucasian population. I will go back to my slides just to show you one of the nightmares that we face. This is a young male who was presented to us in the cath lab with agonizing chest pain. 2 weeks earlier, he had a stent implanted in LED, and this stent was occluded because of stent thrombosis. He was treated with Clopidogrel with a dose of 150 milligrams. We used to use this high dose to prevent platelet dysfunction, but unfortunately, despite the high dose of Clopidogrel, the patient developed thrombus and stent thrombosis, and he necessitated to be changed to another antiplatelet medication. This common scenario is, I think most of us have faced this problem before, and that's why the term now comes: can we assess the function of the Clopidogrel either phenotypically by measuring the platelet function inhibition test, or genotypically by detecting patients who have the mutation of cytochrome B2C19 genes. In the last decade, those 3 studies was conducted to assess the clinical benefit of doing platelet function test among patients who are treated with Clopidogrel. Unfortunately, there is no evidence that treatment with modified either with higher dose of Clopidogrel, either loading or maintenance, or switching Clopidogrel to Prasugrel had led to an improvement in the clinical outcomes patients who are undergoing BCI, either elective or emergency. And this had actually brought the clopidogrel into backyard. In the last decade, many people, they hesitate to use clopidogrel because of its variability in action. But in the 2020, there was actually a great success for clopidogrel against other antiplatelet medications in the form of this study, which was conducted in Europe. There are 1,900 patients who were involved in this study, and clopidogrel was tested against ticagrelor, the most potent antiplatelet drug available, and it showed that ticagrelor was not superior to clopidogrel in reducing peri-procedure myocardial necrosis after elective BCI. And this actually brings the light back to the life of the clopidogrel. So we have an idea that clopidogrel is a good drug, still is effective, but we have to detect people who are not candidate to use clopidogrel, i.e. the patients who have these genetic mutations. And this study was conducted in the United States and published in 2022. 3,000 patients, 1/3 of them, they have chronic coronary syndrome, was tested for cytochrome B2C19 gene. And these patients, this group of patients, was selected for clopidogrel, prasugrel, and ticagrelor after stent implantation. And this is the study design. And the conclusion was the real-world data demonstrate lower atherosclerotic risk in patients in cytochrome B2C19 loss of function carriers treated with alternative therapy. So patients who have this mutation, we can switch them to another antiplatelet drugs, but patients who don't have this mutation, we can treat them with clopidogrel in the traditional way. So what are the guidelines tell us? The guidelines still stick to the clopidogrel. Clopidogrel has class 1 indication in case of aspirin intolerance. The European guidelines state that a second antiplatelet can be used with aspirin in preventing thromboembolic phenomena in patients with high risk. But here we have to weigh the risk of bleeding against the risk of thrombosis. And most of our patients, unfortunately, they are old age, they have high risk of bleeding, so the only drug or the only medication safe can be given to these patients is clopidogrel. So these are for the prevention. And for the treatment of post-PCI patients, still clopidogrel has the class 1A indication. And for patients who have atrial fibrillation with another indication of stent implantation, still clopidogrel has class 1 indication, which indicates it's the safest antiplatelet which can be used in patients with chronic coronary syndrome treated with stents. This is just to show that, summarizing what I have mentioned before. So I will conclude that antiplatelet therapy with aspirin and B2Y12 receptor inhibitors constitute the predominant strategy to prevent recurrent ischemic events either in acute or chronic atherosclerotic disease patients. Platelet response to clopidogrel is characterized by large inter-individual response variability due to complexity in pharmacokinetics, pharmacodynamics, and pharmacogenetics of this drug. Platelet function test or genetic testing may be considered in specific high-risk patients, history of stent thrombosis, compliance issue, suspicion of resistance, or high bleeding risk. Recent studies showed potential benefit of tailoring the antiplatelet therapy to the individuals, which i.e. that we can use the genetic testing to determine patients who have loss of function genetic related to clopidogrel metabolism. And I will finish with this. The old horse is still capable of doing the work, so please don't get rid of it. Thank you very much.